I'd like to welcome Alan Simpson, who's Professor of Collaborative Mental Health Nursing at City University London. Alan has a long-standing active interest in promoting service user involvement in education and research, facilitates a service user advisory group on research at the university. He's also chair of Mental Health Nursing Academics UK, an organisation which represents more than 60 universities engaged in mental health nursing education and research. Recently, Alan has been awarded the Ellen Skellen Lifetime Achievement Award for his contribution in the mental health nursing field.
Thank you. Thanks for coming along, everyone. It's weird because it is being misnamed as the Lifetime Achievement Award. There's actually two awards. One of them is a Lifetime Achievement for very old people. And then there's the other one, which is the Ellen Skellen Lecture, which I'm giving for youngsters, up-and-coming youngsters. Today we are recording this and we're also filming this, and hopefully it's going to go up on Moodle for staff and other people who couldn't get here. So if you could put your phones on silent and switch your toasters off. I always hate it when the toast pops up when you're in the middle of talking. It's just very irritating. Okay, I'm going to give up on that joke. I've used it too many times. It doesn't matter. Okay, thanks for coming. I'm going to give a bit of a brief overview to why we think about involving service users and carers in any research, and certainly in mental health nursing research. And then I'm going to draw on some examples of some various projects we've been working on here at City University over the years, and different ways we've involved service users and carers, and what some of the advantages have been, and some of the challenges as well. And end up talking a bit about the Service User Advisory Group on Research, Sugar, that we work with at the moment. And I just want to say right from the start, all this takes place because of all the support and input from many of my colleagues, some of whom are in the audience today. So it's never a lone journey, these things. Lots of input from lots of people, and that's greatly appreciated. So we often talk about service users. Who are service users? Well, it depends what you're researching. It's very much context specific. It may be students if you're doing educational research. It may be staff if you're interested in researching staff about things. But very often we're talking about patients, users of health services where we're conducting research and that we're interested in, or members of the public, and that can include carers, family members, friends of people using services. They themselves, of course, may have contact with and be using services. So I think sometimes people get hung up on worrying about who it is that we're talking about, and I think what's much more important is you think about the specific project that you're running and you're involved in, and think about who is it most appropriate to try and consult with and involve, depending on what that study is. But we can talk about that more later if you wish. What do we mean by involvement? Very often and traditionally it's meant actually involving people in the research as participants, the people we're going to do tests on, we give questionnaires to, or interview or whatever. And that's not what we're talking about here. What we're talking about is being involved in actually undertaking the research some way, actually participating in perhaps the design of it, of the collecting data, the analysing data or whatever. And we'll look at that in more detail. And many people talk about there being a continuum of involvement, or a ladder sometimes, from a basic level of consulting with a person or a group of people, up to what would be called user-led or citizen-led or citizen-controlled research. I'm going to touch on the latter, but only briefly. I'm going to talk more about the consulting, and what we do more often, hopefully, is collaboration, working alongside and with members of the public. And as I said, it's very much context specific, and it depends what you're doing and what you want to achieve. And we'll say a bit more about that as we go along. So why involve service users in research? I'm sure many of you already got a good idea about this. And first of all, it helps us ask different questions. Very often we're quite set in our thinking about things, and we have ideas and interests. We may be responding to research calls or whatever, and our understanding of the issue, the problem, the challenge may be going along a particular line. And very often you find by consulting with users of services, they will challenge your thinking and they will come up with ideas that take you off in a different direction or a complementary direction, broadens your outlook, and that's an incredibly valuable thing to be aware of. It grounds the research in the experiences and the priorities of service users. The things that seem to be of priority to funders, to ourselves, to maybe our clinical colleagues, aren't necessarily the priorities for users of those services. Not the things that they think are most important. And what's been very interesting is when we collaborate and consult with our service user colleagues, how often, almost in the very first words that we're putting in there to talk about what we're thinking about doing, we're getting challenged in those very initial words, our very initial assumptions about what we think we should be doing. And they're saying, why are you looking at that? Why are you going to do that? Why not this? And that's an interesting dialogue to have. It's quite threatening, it's quite challenging. We'll talk about that later. But it's a very useful consultation to have. It's just worth saying as well, although we say the priorities may be different, they may not, of course, be different at all. They may be quite similar and may overlap. And there's a couple of small studies which have shown that very often the views of service users, and including the views of quite active service users, very often overlap with those of, say, clinical staff and researchers. And that sort of addresses the issue of people often say, well, these people you're consulting with aren't representative of the wider body. Well, they may or may not be, and we can explore that in more detail. But actually, very often their views will overlap quite strongly with the wider patient body. It can help us think about using different methods, participatory research perhaps, looking at use of focus groups or interviews, maybe when we were thinking about just using questionnaire methods or survey. And it may help us think about involving service users in the actual process. It may help us involve the development of different instruments of user-valued or patient-reported outcome measures, becoming more and more established now in mainstream research, but not so long ago was quite a new and challenging idea. It may shed new light on old questions, and it may help you in your recruitment of participants, of dissemination of your findings, and more importantly, arguably, the implementation of those findings to actually influence practice. Increasingly, though, it's required by funders. Certainly in health services research, the vast bulk of the National Institute Health Research funding streams, and also many of the main research charities, are now saying they want evidence of your patient-public involvement in your bids. And I know from experience now that applications are being turned down because they don't show evidence of good, well-thought-through public-patient involvement. It's morally right. We're talking frequently about publicly funded research, publicly funded health services. It's morally right that people who use those services should be involved in deciding what should be researched. I think, massively important there, it frequently taps into what are often the hidden talents amongst the service user body. And whether it's in mental health, whether it's in anything else, because someone has had experience of an illness, or experience of using a health service, doesn't mean that they don't have many other skills, qualities, abilities. And we often find ourselves working with people who've got degrees, master's degrees, or experience in market research, all sorts of things. And even if they don't have that, they often have other experiences, life experiences, which are incredibly valuable and add to the sum total of what you're trying to do. And I think another thing that's really important for us working in universities is that we are part of our communities. I think we should be part of our communities and an active part of our communities. And we have an opportunity to contribute to our local communities and our local citizens and help empower and inform and build capacity within that community. And I think we have an enormous privilege, actually, to be able to do that and look at ways of doing that more. And what I would say is, well, it's massively good fun. It's tiring, it's challenging, it is hard work, and I'm not going to pretend it isn't. To do it well requires a lot of thought and a lot of energy, but it is fun, and I would say without fail, any time that I've been involved with working alongside service users, it's added to my experience, added to my life, and been great fun. I've learned a lot along the way. So what sorts of ways might people be involved? As I said before, you can talk about a continuum from consultation through collaboration to user-led or user-controlled. So in a very often more traditional sort of lower level terms of involvement would be having a patient or maybe a couple of patients or a member of the public on your project steering group or advisory group. I've been here 11, 12 years. We did that when I came here. We've been doing that for a long time. There's arguments for having more than one person so they can support one another. There's arguments for making sure there's a role description and there's some guidance about how they may contribute to that advisory group, and you can maximise their input into that process. So it need not necessarily be not a particularly fruitful exercise, but it's certainly at the lower end of involvement. You can go to people for initial ideas about research. You may want to bounce some ideas that you have. You may want to go out and speak to people and find out what they think are important issues, what are their priorities, and then build on that. You can consult and collaborate on the design of the studies, looking at how you're going to design that study. What's the best way to answer the questions that you're looking at? You might involve people in developing instruments and testing those instruments. Looking at revising questionnaires and the questions in those, interview schedules, focus group schedules and so on. Getting people's input on what questions work, what doesn't work. Sometimes the wording can be quite difficult for people to get what it is you're trying to get at. Or we use too much jargon or whatever, and it's nothing better than putting your interview schedule in front of a group of service users who will start to tell you what's working for them and what isn't, and helping simplifying your ideas. Similarly, designing and testing out patient information leaflets, information forms for consent, for just general information about the study, really can be very helpful. Very often we find people asking us to use more pictures, simplifying their language, using colour, so on and so forth. Sometimes there's a tension between what our patient and service users are asking us to do and what ethics committees are asking us to do, and you have to try and find a way through that. But it's useful nonetheless. So similarly, advice on ethics applications, certainly talking through and thinking about what are the ethical challenges for this research. And we've had some fantastic experiences recently when we've had master's students and postmaster students coming to our service user group and talking about their studies in their preparation for the ethics committee, and just how many ethical issues the service user group were able to think about and challenge the researchers on. And it really got them to think about things that they really hadn't given attention to, but would undoubtedly come up when it went to the ethics committee. You can work with service users to promote your studies, to help recruit participants. We often work with people who are linked into wider networks, members of patient groups, patient organisations. That can be a very good way of telling people about the study and recruiting potential participants. And increasingly what you're seeing, and what we're increasingly doing, is employing service users as researchers. So employing people to conduct interviews, to take part, help run focus groups, distribute questionnaires and so on. I'll be talking more about that in a moment. I think it's true to say that across the health research world, what's happened less is involvement in analysis. And I think probably because of the time commitment, very, very timely process, and probably more challenging and difficult if people don't already have those skills. But increasingly that's beginning to take place, and we've done some small bits of that just recently, and I'll talk about that. But undoubtedly, looking at the results you have, some of your initial findings, results that come out of your research, discussing those with the service user group before you go on to make your sort of final conclusions and recommendations can be a very useful process. It can help you think about what the findings may mean in a slightly different light. And similarly, contributing to reports and papers, it can strengthen what it is you're saying and how useful your reports and papers may be to a wider audience. And what we're doing increasingly now is also collaborating in conferences, in workshops, in disseminating findings from research, and talking with people about how best to implement the findings. And if you want people to be supporting and backing your recommendations, there's nothing better to be working collaboratively with a patient group who are going to be strongly there on your side. And then going around full circle, very often what comes out of your studies is thoughts about, well, what do we need to research next? What are we going to build on? And again, the service user group should be feeding into that. Do you want to come and sit there? So I'll just talk about some of the studies that we've been involved in here at City in mental health nursing research. Some years ago we were funded by the National Institute of Health Research to look at the use of special observation in inpatient wards and how we reduce self-harm. We looked at a wide range of other things in that. And we ended up collecting data from 136 wards across England. And we had service user representation on the advisory group. And that person also contributed to the instrument design and the testing of that. So she, as well as putting her own wisdom and expertise into those discussions, also took some of the initial measures we were planning on using and took them to 2 service user groups that she had contact with elsewhere in London and got their feedback, which we then fed back into our design process. She wasn't in that study involved in the data collection or analysis, but when we came to interpreting the findings of the results, this is Diane Hackney, who's a service user, a researcher and consultant. She was very instrumental in identifying a particular finding and the potential for that for the further research. And we found that patients were saying they were very nervous about leaving inpatient care. They were worried about leaving the support of 24-hour nursing care and presence on the wards, and most particularly of missing their peers, their fellow patients on the wards. And they said having people around them to chat with and share experiences was a very useful thing. And Diane, our service user representative on that study, said what you need is a buddy system. You need patients with experience of inpatient care to be linking up with people as they're discharged and supporting them following discharge. And that led to us putting together another study on peer support, which I'll talk about in a moment. So there was a brilliant example of the service user input helping us to think about something in a different way, which none of us in the research team had previously thought of. Diane was also involved in another study we were carrying out around the same time. This was a Tompkins acute ward study, named after Elizabeth Tompkins, who funded that study. It was a longitudinal study, took place over 2 to 3 years, and we were collecting data from 16 inpatient psychiatric wards, mental health wards in East London, across East London. And Diane again was involved on the advisory group, but in this one she was involved as well in the data collection. So we ended up conducting 119 interviews with service users who were currently on inpatient wards. And Diane completed 100 of those interviews, and another research assistant and myself did the other 19. So Diane would go out with a research assistant colleague and would recruit patients on the wards into the study. And during that recruitment process would say, I'm a service user myself, I've been on some of these wards, I've shared some of this experience, and then she conducted the interview with that person's agreement. And then Diane also was involved in some of the analysis and some of the interpretation of the findings from that study and in the papers which were drafted following. So very much more hands-on involvement in that whole study. And I worked very closely with Diane on that study and was supervising her involvement. And for me personally, it's been a very interesting and influential time in my sort of research career of working alongside service users, in that there were times when I was struggling internally in terms of thinking about how best to talk with Diane about certain things, because I was worrying about labelling her as a service user. So I'll just give you a snap example, which I've spoken about publicly before and Diane knows all about. Was we went for a coffee one day in between interviews out in East London, and when we were chatting, I thought Diane just wasn't too well. I got a feeling she wasn't too well at that time. And I was really hesitating to say anything and check it out with her, though, because I didn't want her to think I was sat there being a nurse and doing the diagnosis bit and noticing the signs and symptoms and ticking them off. And I was sort of struggling with it in my head a bit. Anyway, I chose not to say anything. And the following week we met up and we went out and did some more interviews, and we went for a coffee, and we used to talk about Trumpton Town and various interesting things like that. And Diane said to, and I was feeling a bit rubbish that day. I forget what it was. I had a bit of a cold or something. And Diane said to me, "Oh, you don't seem your usual self today. Are you feeling okay?" And it was, and that sparked me to have a conversation about how I'd held back at saying exactly the same thing the previous week. And from then on, we got into this much more equal and honest relationship with one another, when we were saying it's okay for us both to check out with each other and to say if we're a bit concerned about each other or anything like that. And it was a real change in my thinking and my understanding about being much more on a level and not worrying so much, being so clumsy around being right on and all the rest of that. And it was much more to be human and real, and just as a colleague say, are you okay, and just checking that out. And it was quite an influential moment for me, and I think it's sort of changed a lot about the way I try and think about working. Anyway, just sort of share that with you. Moving on, I mentioned about the peer support study. This came out of the City 128, flagged up by Diane. So she said a buddy system. We looked into the literature. We found lots around befriending services, mutual support, peer support, lots of literature in the States and Australia and elsewhere looking at peer support. And that led to us designing a proposal which got funded by the National Institute of Health Research to conduct a pilot trial of peer support for people being discharged from inpatient care to home, with a view to the peer support workers providing support. And I believe there's a couple of peer support workers in the audience here. Nice to see you. Thanks for coming along. And that study was interesting. It was a challenge, but it very much was driven by that service user involvement. We had service users, a number of, I think 4 service users on the advisory group. We had service users involved in the recruitment of the research assistant, of the peer support coordinator, and of the peer support workers themselves. So we had an open day where local service users could come along and find out the idea of being trained up to be a peer support worker. And we had a number of service users involved in that recruitment day, involved in activities and in making the decision about who would be invited to take part in the training. They were also involved in the design of the study, in the design of recruitment leaflets, and then towards the end, when we were analysing some of the interviews with the peers and the focus groups with the peer support workers, they were involved with us in a group of service users in analysing that data, and have helped us come up with the final themes from that data. So very much a much stronger presence of service user involvement throughout that study, and it worked very well. I've been working with some colleagues in Kingston St George's University, Steve Gillard, who's got a good, strong reputation of working collaboratively with service users. He does some fantastic work. He's also done some very interesting work looking at whether service user involvement makes a difference. I'm not going to say much about it here, but Steve Gillard, look up his publications. There's some good stuff. He's a good chap. And on that proposed study, which at the moment we haven't got funded, but we're reworking it and trying to get funding, we've got service users involved in the project team as co-applicants. They're on the advisory group. The project manager, we're proposing to employ a particular person to be the project manager, and is a service user research with experience of both service use and of research. And we're aiming in that study to employ service user researchers to conduct interviews. Similarly, a study with the short title of COCAP, which is about recovery-focused care planning and mental health services. This is one that I'm leading on with colleagues in Wales, in Swansea and Cardiff. And we're going to be looking at recovery-focused care planning in Wales and England and making comparison between the two countries and within different services. We have, as a co-applicant, Alison Faulkner, who's a leading service user researcher in England. We have a lived experience advisory group, so we have a project advisory group with academics and service managers and others in it. And we have a lived experience group of about a dozen service users from different parts of the country, all of whom have personal experience of being under the CPA, having care plans and care coordinators. And 2 of the members of the lived experience group will also be on the project advisory group. Throughout all of that, contributing to the design and development of that study, and monitoring it and keeping an eye on it as we progress. And similarly to the peer support clusters trial, in this study we are going to be employing 4 service user researchers. There'll be 2 based in Cardiff, 2 in London, who will be working alongside our more traditional research assistant, and they will be going out and recruiting service users and carers into the study and conducting interviews with them. So that's just started, again funded by the National Institute of Health Research, and it's going to be an interesting project to be involved with. And then something which probably we're becoming very well known for is our service user group advising on research, titled Sugar, named by one of the members of the group. And we've been working with this group for about 3 years now, so I'll say a bit more about it. There are some of them, some of us, and not all, but some of them. So we got funded from National Institute of Health Research. We had a programme grant. It was granted to Len Barnes, who's a professor here. He left a couple of years ago. And in that programme grant, we built in a request for funding to set up, support and facilitate a group of service users that we would work with over a long-term period of time, over the 5-year course of that programme grant. So the programme grant is there to fund a programme of research over 5 years, looking at conflict and containment in psychiatry. And this group has been set up to work with us on that and other projects. So we're basically working with that group now on all of our research projects within our mental health team, and our MSc students and PhD students and so on can come along as well. And occasionally we have people from outside. So what we do is we've got about 14 members. We meet once a month for about 4 or 5 hours. On average, we get 11 people turn up at every meeting. In the morning, we have a couple of sessions where people can come along and present any aspect of research. So it might be an initial idea, knocking around some ideas. It might be the design. It might be testing out an instrument or thinking about what instruments to use, asking about what content should be in an interview schedule. It might be presenting some initial results and what do people think about that, asking for involvement in analysis. It might be putting together a presentation to present somewhere or presenting jointly. And basically the person comes along and presents, and we use a variety of different methods. Sometimes it's the whole group brainstorming and discussing the project. We might break people up into pairs or into small groups. And we might do written work sometimes. There's a range of things done. And we've been going for 3 years now. It's been an enormous success. We've evaluated it, and we've had lots of very, very positive feedback, both from the members of the group and from people, researchers who've come along to the meetings. And we've presented jointly at a number of research conferences, international research conferences. And it's going great guns. In the afternoon we meet, we have a social time at lunch, we have lunch together. Everyone is paid for their participation. And that social aspect I think is an important part of it. And then in the afternoon, Julia Jones, my colleague who's in the audience here, leads on development, capacity building amongst the members of the group. So we've been teaching and developing people's understanding of the whole research process, of doing literature reviews, accessing information on the internet, about finding out about different approaches to research, different methodologies, different methods. We've done work on coding and analysing qualitative data. We've done stuff on developing questionnaires, on looking at interview schedules, all sorts of things. And again, as I said earlier on, that's very much about capacity building within the group, but also sort of giving information and knowledge back into the local community. Many of these people are linked in with a range of other groups, and so you're sort of contributing to that wider community. And it's been, I said before, there's no sort of shortcuts to this, and I think we put an awful lot into this group to make it work. There's a lot of time and thought and planning. Anyone who works within our team tends to contribute to this meeting. None of those inputs are paid for within the funding we got. That was a relatively small amount of money. But the pay that we get back, the reward that we get back is enormous. It undoubtedly adds to the quality of our research. It challenges our thinking. It takes us in new areas and exciting areas. And I think there's something very, very fulfilling about the process in itself. It's a rewarding thing to do, and it's a very enjoyable thing to do. And I think without fail, just about everyone who's had involvement in this group comes away from it a better person for that involvement. I'll just touch very, very briefly on a couple of examples of user-led research. This is at the other end of that continuum. And I'm just going to talk about some of the work that Diane Rose has done, who's based at the Institute of Psychiatry. A couple of examples. She conducted and led on, again, a study funded by the National Institute of Health Research a study of electroconvulsive therapy, ECT, in mental health services, and conducted a systematic review from a patient perspective, and they reviewed and critiqued the evidence around ECT in published papers. There were two key researchers in that study. Both had personal experience of receiving ECT, including Diane Rose herself. The study focus, design and execution were all user-led, and the results ended up, after a bit of a battle by the way, being published in the BMJ, in the British Journal of Psychiatry, and ended up influencing the NICE guidelines on ECT, and in particular it was around the impact of ECT on memory loss, and they changed their stance on that, as did the British College of Psychiatrists. And what was interesting is Diane and her colleagues didn't set out from a position of being against ECT. Diane has spoken out in favour of it and is not against it, but what they were more concerned about was the way evidence was collated and disseminated around that treatment, and how seldom the views and experiences of service users were included in that. And that's what they set out to make sure happened, and did very, very successfully. Another study Diane led on, who's probably one of the leading mental health service user researchers in the country, if not the leading, was a model for developing outcome measures from the perspectives of mental health service users. As I said before, the whole idea of patient-reported outcome measures is becoming pretty mainstream now, but that's all quite new. And their work describes a methodology for developing outcome measures for use in large studies, and that they are entirely from the perspective of mental health service users. So they use mixed methods, starting with a participatory and qualitative methodology, and then proceeded to psychometric testing of these new measures. And at all stages, the researchers are themselves mental health service users. The references there at the end of these slides, the full references there, and we'll be putting those up on the Moodle site for you. So just talk a bit about some of the challenges and barriers around involving service users, patients and public in research. I think it's fair to say over the years there's been some resistance and anxiety amongst researchers, not all, and it is changing. And I'm not entirely critical of that. I think for people who've been working in a particular way, in a particular tradition over many, many years, it can be quite challenging and threatening and a bit scary to suddenly be told you've got to be working in a very different way, and working in a way which is uncomfortable for you and alien. And there may be people who are incredibly good at doing research, but not incredibly good at working collaboratively with others. And in fact, there's some argument that some really good researchers, they're almost really good because they can sit down there, be entirely focused, dismiss everything else, not get distracted by anything else, and just sort of do what they need to do. And the skill set required to work collaboratively is something else. So understandably, it causes some anxiety. And I think whilst there's been quite a lot of attention on thinking about how do we develop the research skills in the service user community, and I think quite rightly, I think we've been less focused on thinking about how do we develop the skills amongst our staff to enable them to feel confident about working in collaboration with members of the public. And I think it's something we need to put a bit more time and thought into. There's some concern that it's time consuming, and I would say yes it is. As undoubtedly, if you're going to work in a collaborative way involving discussion, consultation, that process, it takes time in itself, and it extends the time it takes for you to do any bit of the study that you're going to do consulting with others. It has to, it can't not. You can go through a tokenistic effort of going out and sort of pretending you're consulting, but to do it properly and to really take on board what people are thinking and go away and rethink about how you thought you were going to do something is going to add to the time. And that, of course, has cost implications as well when you're thinking about a costed research project. So you do need to think about that. So what you've got to increasingly do, certainly if you're talking about funded research, is to think that through realistically and sensibly and start to take account of that. And fortunately, our funding bodies are now beginning to appreciate that and are realistically funding patient involvement in studies. Of course, if you're self-funded, if you're not at that stage of getting externally funded bids, it is more difficult and more challenging, but there are ways of doing it. There are things like our sugar group. There are groups of patients out there in the community who you can go out to and say, could I come to one of your meetings and talk about my study? So there are ways, but undoubtedly it takes time, and it does take some money. And if you're going to set up a group like we have, and you're thinking about paying people, you might be paying transport, catering, food, and so on. You know, those things do add up. One of the big criticisms is probably the issue of representativeness. And there's always that feeling of, you know, we consulted with these service users, and people said, yeah, but their views aren't typical. And as I said before, there are a couple of small studies which looked at the views of service user activists, general service users who weren't belonging to any particular active group, and staff. And what they found was, this was in mental health, what they found was a strong overlap in the areas that people thought were priorities for areas of research. And then within each group, and carers as well, and within each group there were some slight differences in tone and some topics which weren't necessarily shared. But the bulk of what people were interested in were strongly overlapping. But also, for many of us, we aim to recruit a range of people to try and get a range of views and voices. And very many of the people that we have contact with are themselves members of wider networks. And what you can aim to do, you can't guarantee it, but what you aim to do is you're asking almost those people to consult with their wider networks in the process of consulting with you. And many do that very, very well. And there's also that whole argument, well, which researcher, which nurse, which psychiatrist is representative of other nurses, researchers? And that's true. I don't think it's a particularly helpful argument, but it is true, undoubtedly. But it is interesting how some of the people who are strongest who have the strongest criticism are themselves not willing to think about that themselves, that their views are probably far from representative of their wider bodies. I think what's more important about this is we can get hung up on arguing this and going around in circles about it, and it's about like worrying about the language of it, rather than getting out there and doing something. It's better that you get out there and start, and do it in a bit of a flawed way maybe, but you've made a start, and then you can start to build on that. And the more time we just spend going around in circles worrying about it, the less we actually do, which is meaningful.
Well, I suppose from my point of view, wouldn't it be more about the integrity of the researcher rather than representative of them? Because if they've got integrity and they're looking for honesty and truth, that could be more important than them trying to colour the results with their particular ideas and opinions. Yeah,
I think people's concern is that if you consult with someone, say you were going to do the study on ECT, and you say, I consulted with a service user, and then someone says, yeah, but that service user is a member of a group that's arguing for the scrapping of ECT. They're not, they're probably not representative of the wider patient body. So I can see why people would be concerned about that. And I think as researchers, we have a responsibility to try and consult as widely as possible and involve as widely as possible. So I think we need to be, I think you're right, we need to make sure we have integrity about how we go about that consultation, that collaboration. But not to get so hung up on about that we're agonising about, oh God, I've got 4 people, are they representative? I think, well, you've got 4 people, let's get on and do some work, But yeah, thank you. Training and support, undoubtedly, it really helps if you can provide training, development for people that are going to be collaborating with you. There's a nice piece of research by Rachel Lockie some years ago, which looked at people who got involved, service users who got involved in research in the Sussex area, in health services research, and found that those who had received training and ongoing support were much more likely to remain involved, got involved in a series of studies, rather than sort of had a taste and thought, well, this isn't really for me, and sort of dropped out. So it's about developing that confidence, the skills, the knowledge, the understanding. If you're a researcher, you just know all the language, the jargon that you almost know without knowing you know it. You can say things without even realising this is a technical speaking from your research world. And you have to take people with you and develop people. So some of it's about us explaining things in an accessible way, but linked to that, we need to be developing people's skills and knowledge and understanding. Interestingly, increasingly now, there are training courses, workshops and things aimed at patients, service users, public, to do very much that. So you don't necessarily have to do it all yourself. I've duplicated time consuming. That's just to emphasise to you that it really is time consuming. It can challenge your views and thinking, and for some people that's difficult. I've got to say, for all of us it can be difficult. If you feel quite strongly about something, you really think, I really want to do this, and I really want to do it in this way, and you've got a group of people going, I don't think you should be doing these questionnaires. I think it would be better if you went out and do interviews or focus groups, and you're going, no, I want to use this questionnaire. It can be quite challenging. And I think what's worth thinking about in this as well is we don't necessarily have to take what a group of service users say and do it exactly as they say. To me, what's much more important is that we have a dialogue. It's an honest and open dialogue, and within that, and I'll go and say a bit more about this in a minute, you can acknowledge some limitations in that you're faced with. There may be requirements on you to do certain things, but you can honestly show the bits that you're taking on board, and you say, okay, we're going to change that as a result of this discussion. However, I've heard what you've said about this bit, but having thought about it, and for these reasons, we're not going to do that, we're still going to do this. I think if you're doing that honestly and openly, that's fair and reasonable. I think that's better than doing what I saw someone do the other day at a conference, when they got challenged about the inclusion of a particular question in the interview schedule. They got quite defensive about it, and then they said, well, that's the trouble with consulting with service users, because that was the question that they wanted in it. And I thought, impressive. There can be tensions between researchers, including service user research. And what I was going to put up, originally I was going to put up, you can have tensions between your mainstream researchers and service user research. But the reality is, you get tensions between researchers. If people are coming together and working on something, you have different thoughts and ideas about it. And we just need to recognise that and acknowledge that. What you do is try and put in processes and ways of working where you deal with that in an intelligent and thoughtful way. So you give space for discussion and dialogue, and have some process of how do you come to an agreement when you have different views on this. And building those processes. But the idea that it's only the service user researchers you're going to have the conflicts with is a nonsense. We do need to think about issues of illness and relapse. And again, for some researchers, this will be something that would put them off involving people and patients, particularly with long-term conditions, people who might suffer relapse and so on. And that's why one of the strong reasons for working with a group of people rather than individual. If you have one person and you're absolutely dependent on them, if they're having a bit of a difficult time, they feel a responsibility to keep going, even though it's probably not against their interest, which is what Diane Hackney was talking to me about. So that was very much what she felt. She felt this enormous responsibility to keep it all together when she was feeling a bit rocky. And we sort of are worrying. We're thinking, I don't want to put too much pressure on them, but we really need to get these interviews done. So it is better if you've got a group of people that you can work with to spread that load. But you do need to build in a recognition and appreciation that you're working with people who may well have some difficulties and need to take a bit of time out. And what's important when you start that relationship with the person is that you bring that into the open and you talk about it. And you can have it written into a role description. You can say to the person, I realise there are going to be times when you may well be having some difficulties. What's important is you just let me know, and then we can negotiate what you want to do. It might be about flexible working, it might be about less input, it might be about taking a few weeks off or whatever. The more you do that, the less likely it is the person's going to need it. Because what you paradoxically are doing is giving them permission, and you take off the pressure. You take off this pressure that the person might put themselves under to be working at a particular level. And it's the pressure in itself that very often causes the difficulties. So by having that conversation early on, and meaning it, and generally putting in the process to make sure that you can act on that, will be better for everyone involved.
But not everyone will have the insight to realise they're getting ill.
So one thing, you're quite right, not everyone will have the insight to appreciate when they're becoming unwell. So, and that can be difficult, of course. It can be difficult to raise that with someone you're working closely with, to say, well, you know, exactly what I was talking about earlier. But maybe what you can try and do, say if you're employing someone to work on a study with you, it may be something that you could try and have a conversation with early on to put in place something about, you know, what should I do if, you know, have those sorts of conversations. I think can be really useful. Again, for real genuine involvement and to enable people to do it, we do need to think about people having children that need childcare. Very often people are caring for someone else with a condition and have dependent care. There may be travel difficulties and issues. We work with people who not only have mental health problems but often have other physical problems. We've got people in wheelchairs, we've got people with visual difficulties and so on. And it is challenging. You can not think about things, you can forget things, and it means people are having to raise it with us and we have to take it on board and think about it. So, but it changes you, it makes you think about it. We've gone to conferences together with someone in a wheelchair, and I tell you, it doesn't have to open my eyes to the reality of living with a wheelchair. You know, it's and similarly with someone with visual difficulties, we have to think about when we're presenting information, when we're doing handouts, how we present that information. But that's good. That's making us think about what that experience is like for that person and how it impacts on healthcare and receipt of healthcare and so on. And there are issues, as again there are with multiple researchers involved in studies, of ownership of studies and of authorship. And you do need to think about and address and put on the agenda. You know, ultimately, if I'm being funded by a research body to lead on a project, I'm ultimately responsible for it, and I own it, and within that I can then have co-applicants, I can have people working on it, and we negotiate their input and involvement in that. But the buck stops with me as the primary investigator, and that's how it is. With things like authorship, it's a bit more complicated. If you're thinking about if we're going to write a research paper and service users will be involved in that analysis, you know, are they going to get named in that as individuals? Is it going to be the group? And those sorts of things, I think, are quite difficult ones to tease out and discuss. I'm not saying it's easy, but there are things that are worth thinking about. And how do we best deal with that? I'm just looking at the clock. I'm going to give a few tips for success, drawn on our experiences, particularly with the Sugar Group, but over a range of projects. You do need to commit time and resources. You can't just turn up 5 minutes before you're going to do some collaboration and think it will work. You do need to think about how you're going to work with people, preparing things, making sure the room's suitable, that people can access the building and access the rooms, that there are toilets where people can get to them. If you're going to provide catering, to make sure that that's there and so on and so on. You do need to think about it, plan ahead, and commit time and resources to it to make it a success. Plan and anticipate difficulties, possible tensions that might be there, and have conversations about those things. Don't think you have to sort it all out yourself. Very often the easiest way to sort out something that's a problem is to talk about it, because other people will come up with the solutions. You can agonise over it. I've done it. You lie awake thinking, oh God, I think I've messed up on this and I've done this. And you go into the group and talk about it, and they just tell you the answer. They just give you the solution. And it's a real lesson to learn. Do take it seriously. It cannot be an afterthought. It's really not worth doing it if you're not going to do it properly. So you've got to take it seriously and think about it. It's very, very useful to have role descriptions, just like a job description. If you want to go out and recruit and ask people to be involved, think about what it is exactly you want from them and jot it down. What sort of skills, what sort of requirements do you want of the person? What do they need to be able to do? Because it's no good asking someone to come and sit on a steering group, and they're going to have to sit in a meeting for 4 hours listening to complex stuff if they really can't concentrate for more than 20 minutes. And, you know, what's the point? You're making them feel awful and you're not getting anything. So think about what you're asking the person to do and say to them, is this something you feel you're up to? Is this something you'd be interested in doing? Is there something else maybe which would be more suited to your skills and your interests? So think about that and use that. Be clear about roles, responsibilities and expectations within any research team. What are we asking people to do? How much responsibility do they have? What are the limits of those responsibilities and so on? Try and be honest about everything, including the limitations on you. When we set up our sugar group, we made it absolutely clear this is not about user-led research. We like user-led research, we think it's a good thing, we support the idea of it, but we weren't funded to do that. We were funded to run a programme of research addressing a particular problem, and that was what it was about, and we were asking people to collaborate with us on that. So we made that limitation clear at the start. It was in the role description. So if people are coming along thinking, I want to do user-led research, we said, that's great, we could point you in the direction of some people who may be able to support you, but that's not something we're able to do at the moment. Maybe in the future we can, but not at the moment. Yeah, be honest about those limitations. Do provide training, development support if you can. It doesn't need to be, certificated, master's degree or something. It can be a 2-hour session on how do you look at, get literature on the internet, how do you use databases, how do you critique a paper. It might be looking at interview schedules and thinking about how do you make them better, what works, what doesn't work. It can be quite easy to sort of, not easy, but it doesn't have to be a fully, full certificated course. Be real, be human, be approachable. That's what makes everything work best. Just be yourself, be open and honest with people, and tell people if you're struggling with something. Tell people if I'm not sure if I'm handling this in the best way. What do you think? People will help you, and you'll be amazed at the riches that are at your disposal. Be flexible. So sometimes you think you're going to do something a particular way and you've got it all mapped out, and you're there 10 minutes in and you realise it's dying a death and it's not working. You're doing some big presentation and everyone's falling asleep, as 6 of you are now, and you just think, okay, this ain't working. And things like when you realise that if you have a big group and you're asking people to brainstorm, you'll have 5 or 6 people who love that and they get stuck in and it's great, and you think this is going really well, and you suddenly realise there's 4 people who've not said a word. And you do it the second time and they didn't say a word again. You need to think, I need to do something different. And it's not that they're failing, it's you're failing. You're not involving them. So do something differently. Do some small group work. Do some written work. We've got people who in 3 years have barely said a word when we're in the big group. But if you do some small stuff, 2-3 people discussing things, they will contribute. If you ask them to write something, they will contribute. If you ask them to draw something, they will contribute. We've produced posters at conferences which everyone in the group contributed. Some of them wrote things, but some of them did drawings, fantastic drawings about what their involvement in our sugar group meant to them. It was brilliant. And people have said, I want that in my journal. They wouldn't publish it in the journal because they were so inspired by it. So just think about imaginative ways of working with people. Do pay people whenever possible and on time. City University, please. It's not always possible. We don't always have funding for it, and you've got to be honest about that. There are people who are willing to be involved because they want to give something back. We shouldn't be exploiting people whenever possible, but people may be interested in opportunities when we can't pay them, as long as they appreciate that's the terms on which we're being involved.
Sorry, just to ask a quick question. I was involved in a project where we worked with some people who had a stroke and had communication difficulties, and we didn't pay them. But there was a conflict because they were claiming disability benefits. And I wondered if you've got any experience of dealing with that, because it's great to pay them, but I know that one of them had issues with the benefits.
No, it's a minefield, and sometimes even when you've taken every effort you can to make sure that payment won't impact on their benefits, it does, because some benefits officers got unpleasant about it. So it's an absolute minefield. It's very difficult to be an expert in it because it changes, and it's often depends on the local office and the local officer and how they interpret something. There are people out there, and there are documents and reports and stuff which give you good advice on how best to approach that. Very often the individual knows themselves, so you can have a chat with them and say to them what's worked for you in the past. A rule of thumb, well actually I'm not going to say rule of thumb because it might well have changed. It's a job to keep up with it these days. And undoubtedly at the moment we're in a climate where there is more pressure on people who are on benefits, that if they are being involved in something, then they're more likely to get pressure to say, well, if you can do that, you can be in work. That is a difficulty. And we have had that in in studies where people have been put under pressure because of their involvement, not because of the amount of money, just because of the time they were giving to it. And the officers were saying, well, if you can do that, you can be in work. And it's a real shame. I've been involved in groups that have put a lot of pressure on government, this is back in the Labour government, to change the way they did, to see that this is an opportunity for people to develop skills and to get a foot into the employment world. There were tensions within the Labour government as well as between Department of Work and Pensions, who wanted restrictions on welfare payments, and other people who were, like Department of Health, who were open to it and said, yeah, we agree with you. And the money people won out in that argument. And it's got worse since. But yeah, the best thing is to look out there, people who are giving good advice. There's a lot of stuff out there. There might be a reference on the end, I can't remember if there is or not. Do provide food and drink whenever possible. Just sharing food together, sharing a drink. It's a nice way. It works across cultures, and it's just a very important way of sharing space together and equalising the relationship, really. You're sitting down and having a bit of a rubbishy old sandwich from City University, and it really helps. Sorry, catering, I just thought this was going to be video, didn't it? Can we edit that? Socialise. The mixing together is an important part of it. It really helps people grow in their confidence, and people will say things to you over the sandwich when you're having a chat, which will be about what they didn't feel confident enough to say in that group meeting. But it helps just build sort of people's self-esteem and feeling of being respected and liked as a person. It's massively important. Say thank you. You can't say thank you enough to all of us at all times. But do it. Do appreciate what people are giving to you. And occasionally, ask people what's working and what's not working. What do they feel could be done differently and better, and act on that. It's no good asking them that. And if they say, well, the room we're in is always too cramped and it's too hot, there's no point just keeping on meeting in that room. Change it. Find a better room. Some things may be difficult to change, but you can try it. Final slide. Lessons learned for hard times. We're in this time of great austerity, and it gets harder and harder and harder to find finances for things. So I just want to say a few things. Working alongside service users is enormously rewarding, improves your research and ideas. It can be great fun. It is time consuming, and it can be draining on your energy, undoubtedly. It can be hard work because you're having to think about a lot of things. It's just, you're just thinking about your research ideas and how to develop that, but you're also thinking about how best to work with a group of different people, and you can't do that without investing in it emotionally and psychologically. But it's well worth it. What I would say in the positive sense is that certainly across health and social care research funding, whether it's from government down through National Institute of Health Research or through related health charities funding research, they are all asking for patient-public involvement, all of them. They want to see evidence of it, and they don't want to see tokenistic involvement anymore. There are increasingly large sections in the application forms saying, have service users, patients, public been involved in the design, in the development of this project? How are they going to be involved in managing it and the conducting of it and implement? They want to know. So you can put that in now, and you can cost it in, and you can get it funded. If you've got a good, having that bit good is not enough. You still have to have good science and good research team and a good idea and all the rest of that. But you can build that in now as an important part, and we should increasingly be doing that and thinking about, how do I fund this? I've got to say, a little warning, in our COCAP study we've done that, and we've got some good funding for patient involvement in that study, and even then we've started it and realised we've probably not sufficiently funded certain bits of it, so we're already struggling against the limits of the budget for the lived experience group, and it was just that we probably recruited slightly more people than we should have done, and the travel was a bit more expensive than we thought it would have been, and so even with the best one in the world, you can mess it up sometimes. But there is funding out there, and we should be looking to get as much of that funding as we can, and to work collaboratively with people. Do seek out groups of people and build teams of people to work with you rather than one or two individuals. It's really beneficial. You get a range of views, a range of skills, knowledge, abilities, but also they support one another. And that's one of the most beautiful things about working with groups of service users. It's the way they teach and support and provide support to one another. I could give you many examples, but it teaches us lessons. Actually, it teaches us to think about how do we work best with people and how do we support one another. That's it, I think. Thank you very much for listening.